Good morning, everyone. I'm Dr. Pan from the Department of Urology, the first hospital of Zhejiang University. Today, the topic of speech will be urinary tract infection. The urinary tract infection, according to the location of the infection, urinary tract infection was divided as upper urinary tract infection and the lower urinary tract infection. So, uncomplicated urinary tract infection is an extreme common disorder in women. It's reported of 7 million obstetric visitors every year in United States, which affected about half of women at least once during their lifetime. And the direct cost attributed to this infection in the United States is about $1 billion every year. So urinary tract infection can happen in all populations, from the newborn baby to the older people, but it has a particular impact on female of all ages, especially during pregnancy, and male at two extremes of life, newborn baby or older people. The third is kidney transplant patients. The last one is anyone with functional or structural abnormalities or with a urinary tract. Upper urinary tract infection, we also call it pyelonephritis, and the lower urinary tract infection, sometimes we call cystitis. This figure shows the possible pathogens in urinary tract infection, and we can find the most common pathogens in urinary tract infection is Escherichia coli. Here's the risk factor for urinary tract infection. The first one is obstruction of urinary system. For example, benign prostatic hyperplasia and urinary system stone, or sometimes UPG obstruction. The second one is diabetes. The third one is some iatrogenic reason. For example, if the patient have urethral casters or patient receives cystoscopic examination, the patient may have high risk to develop urinary tract infection. The last one is female. For the diabetes, urinary tract infection are 3 to 4 times more common in diabetic women than in non-diabetic ones, because diabetic neuropathy affects bladder emptiness, and diabetic vascular disease increase pressure within the urinary tract, which results from poor bladder emptiness. For the urinary tract infection, here are two potential routes. The first one is hematogenous route. We see of the kidney during the course of bacteremia. And the second one, and the more important one, is ascending route from the urethra to the bladder, then from the bladder to the kidney, 5 ureters. This picture shows the two potential routes, and the ascending route is the more important one. Hematogenous infection, because the kidney receives about 20 to 25% of the cardiac output, any microorganism that reaches the bloodstream can be delivered to the kidney. And the major cause of hematogenous infection are Staphylococcus, Salmonella species. For the hematogenous infection, sometimes the chronic infectious site in skin or respiratory tract. The bacteria in blood circulation, then to the kidney cortex, and the small abscess formed in some cases. Then the infection reaches the renal tubercle, renal pelvis, and the last, which can affect the renal papillary. Was ascending infection, the place from which urinary tract passages emerge is the gastrointestinal tract in female patients because of the location of the anus to the urethra. So usually female patients are at high risk for urinary tract infections. For the ascending infections, the ability of host defense decreases and urinary tract mucosa cells damaged, and the powers of bacterial adhesion, which indicates the toxicity of bacteria, increased. These reasons resulted in organism invade urethra and periurethral tissues, then cause cystitis, and in some cases infections can lead to the renal pelvis and renal medulla ureters. Here is the symptoms of urinary tract infections. The first one is suprapubic discomfort, which is common in patients with cystitis. The second one is dysuria. The third one is alburia. And the frequency, urgency, but in some severe patients, the patient will develop symptoms of incontinence. For diagnosis of urinary tract infections, besides patient history collection and physical examination, we usually advise the patient to receive urinalysis to check the presence of bacteremia and check the urinary concentration ability, check the urinary enzyme to confirm the damage of the kidney or not. But in some cases, we also collect blood samples to check the level of C-reactive protein. And the last one is radiologic and urologic evaluation to check if there are some structural or functional abnormality of the urinary system. Okay, in urine dipstick, sometimes we can find the urine white blood cell increased. We can also find the pyuria on microscopic examination. And the more important one is middle stream urine culture. In some cases, we can find the bacteria count more than 100,000 per milliliter. And that is a blood culture. So in some cases with pyelonephritis, we can find the patient's urinary concentration ability decrease. So during the urinalysis, we can find the specific gravity of urine decrease, which indicates a urinary concentration ability decreased. We can also check some urinary enzyme, beta-2 microglobin, which also indicates the damage to the kidneys. In some cases, we also advise patients receive urinary tract X-ray, intravenous urogram. In some children, adult men or women with recurrent urinary tract infection to check if there are some structural or functional urinary system obstruction, for example, with UPG obstruction or something like that. For the treatment of urinary tract infections, the first one is antibiotics. Usually, we choose some sensitive antibiotics according to the result of urine or blood culture. On this result, we can find the pathogen is Escherichia coli with ESBL negative. But usually, antibiotics should be prescribed 10 to 15 days until symptoms free. The second treatment is water intake. We usually advise patients take 2 to 2.5 liter water every day. The third one is rest. The last one is treat related disorders. For example, diabetes, because hypoglycemia may have effect on the urinary tract infections, renal stone or vaginal infection. Upper urinary tract infection, namely pyelonephritis. Pyelonephritis means infections of the kidney and its pelvis, but from a historical point of view, the term has come to designate a disorder of the kidney resulting from bacterial invasion. These pictures show pyelonephritis in the kidney. About the symptoms of urinary tract infection, besides some urinary symptoms, for example, frequency, urgency, incontinence, some patients can also develop a fever, black pain. For the treatment of nephritis, we should prescribe antibiotics in patients. We also advise the patient have a good rest, take more water intake, and in some patients we also advise the patient receive some medications for urine qualification. The pictures of cystoscopy show the hemorrhage in the mucosa, which indicate acute cystitis. Cystitis are more common in women. Sometimes cystitis just happened after sexual intercourse. We also call it honeymoon cystitis. And the most common pathogen for cystitis is Escherichia coli. The most infection develop from ascending route. But in some male patients, if the patient have low urinary obstruction, for example, benign prostatic hyperplasia, this patient can also have high risk of cystitis. About the symptoms of cystitis, the patient sometimes have dysuria, aldinuria, frequency, urgency. Sometimes the patient complain of subacute discomfort. For the treatment of cystitis, the first one is rest and water intake, and the second, we should prescribe sensitive antibiotics. If the patient complains of severe symptoms, for example, dysuria, incontinence, or aldiuria, so we can prescribe some medications for urine qualification. But for some female patient post-menopause, we can prescribe some estrogen for this patient to decrease the risk for urinary tract infection. This figure shows the difference between upper urinary tract infection and cystitis. Fever are more common in pyelonephritis. In pyelonephritis patients, usually you can find a percussion over the vertebral angle, and you can also find white blood cell test in the urinalysis of patients with pyelonephritis. So you can also find the urinary concentration ability decrease and the beta-2 microglobin increase, and the antibody-positive bacteria in urine positive in pyelonephritis. For the recurrence of urinary tract infection, which is more common in patients with pyelonephritis. For the intravenous urogram, sometimes you can find some structural or functional abnormality in patients with pyelonephritis. But for patients with cystitis, the result of intravenous urogram is usually normal. For the tuberculosis of urinary system, these two pictures show tuberculosis of the kidney. It is reported about 1/3 of the world population is infected with mycobacterial tuberculosis, and there was 8 to 10 million new active cases of tuberculosis every year. In the United States, the numbers of reported cases declined annually until 1985, when the trend was dramatically reversed. Usually, tuberculosis in urinary system is considered a deadly infectious disease with rising incidence. So globally, tuberculosis is the most common opportunistic infection in 8 patients. For transmission and development of tuberculosis, the genitourinary tuberculosis is caused by metastatic spread of the organism through bloodstream during initial infections. And the kidney is usually the primary organ infected in urinary disease, and the other part of urinary tract become involved by direct extension. For example, the tuberculosis in urinary bladder is usually caused by kidney tuberculosis via urethra. And the primary site for infection of genital tract is often the epididymis in men and the fallopian tube in women. For the symptoms of the tuberculosis, the most symptoms are non-specific. For non-specific, the patient may complain of dysuria, adenuria, or hematuria. So sometimes the patient complains of flag pain or fever. And urologists should always consider the diagnosis of tuberculosis in a patient presenting with vague, long-standing urinary symptoms for which there is no obvious causes, which indicate actually tuberculosis is really difficult for diagnosis in clinical practice. The usual complaint of the tuberculosis in urinary system is frequent painful micturition. So, bladder is always a spokesman for renal tuberculosis because the urine contains mycobacterial tuberculosis reach the bladder, which causes the tuberculosis in the bladder. Epididymitis is most common for male genital system. For diagnosis of tuberculosis, the first is medical history collection and clinical investigation. For the laboratory examination, we usually advise patients receive urinalysis and the urine smear and the urine culture to confirm the existence of mycobacterial tuberculosis, but the positive rate is usually low, from 30% to 50%. We usually also advise patients receive blood test for tuberculosis antibody and PPD test. Autonephrectomy. From this IBU picture, we can find classification of the left kidney. The autonephrectomy means the urine, because we have already mentioned the bladder is a spokesman of kidney tuberculosis. The urine contains bacteria secreted from the kidney, reach the bladder by urethra, will cause the symptoms of the bladder, for example, dysuria or incontinence. But in some severe tuberculosis cases, because the lesions in urethra is so severe, which blocks the urethra totally, so the urine contains the mycobacterial tuberculosis cannot reach the bladder. So the patient symptoms relieved, which called autonephrectomy. These two pictures show the renal calyces destruction due to tuberculosis. From these CT scanning pictures, we can find the left kidney tuberculosis. From this picture, we can find the right abscess in the right kidney and the calcification in the right kidney. What's the cystoscopic examination of tuberculosis? Sometimes we can find the golf hole urethral orifice, just like this. You can also find the scar in the bladder wall and the bleeding and ulcer in the bladder wall. For the treatment of tuberculosis, the first one is rest and nutrition. But we also have some effective agents for the chemotherapy. Isoniazid and rifampicin for at least 6 months. Surgery of tuberculosis, including excision of the diseased tissues, including partial or total nephrectomy, and abscess drainage, epididymectomy. And in some patients, we can choose reconstructive surgery, for example, to treat urethral structure. We can also perform augmentation cystoplasty and urinary contact debulking. For some patients, end-staging, and for some end-staging tuberculosis patients, we can perform orthotopic new bladder. That's all. Thank you for your attention.